All right, great. Thanks. Thanks, Taylor. Good morning, everyone. Welcome. My name is Karen Robinson. I'm Professor of Medicine, Epi, and Health Policy Management, and I'm a core faculty member of the Center for Clinical Trials and Evidence Synthesis. I'm also director of the Johns Hopkins University Evidence-Based Practice Center, or EPC, and that's how I know Dr. Umscheid. Dr. Umscheid is a practicing general internist and clinical epidemiologist. He began his career at the University of Pennsylvania, where he was a co-founder and director of Penn Medicine's Center for Evidence-Based Practice. And he also co-led the EPC at Penn, and that's how I got to know Craig. Craig was most recently an associate professor at the University of Chicago, where he served as the Chief Quality and Innovation Officer and VP of Healthcare Delivery Science, with oversight of clinical quality, medical informatics, and clinical innovation. He was also the director of the US Cochrane Network affiliate there. Craig recently, very recently, began a maybe exciting new position as director of the Evidence-Based Practice Center Division at the Agency for Healthcare Research and Quality, or AHRQ. And today we're going to hear more about whether that is indeed exciting and what he thinks about for the future of the EPC program. Please feel free to use chat to send questions during the talk. And I believe that Craig's left some time at the end for some discussion. So thank you for being here, Craig. Look forward to your talk.
Thanks, Karen, for that introduction, and thanks for inviting me. Really appreciate it. I was eager to share some of these details with your team here. So what I thought I would do is just speak a bit about AHRQ, but obviously spend most of my time speaking about the Evidence-Based Practice Center program in the context of AHRQ's overall mission. Let's see if I can make this work here. Oh, there we go. So I don't think we can start any talk about safety or quality or value without sharing some of these seminal reports from the National Academy of Medicine. And this is just to provide some context for what's motivated so much of AHRQ's activities over the last couple decades. So I think you all know to err is human, really put the patient safety movement on the map in the late 90s, sharing that about 100,000 lives are lost every year due to medical errors. And crossing the quality chasm, which came out in the early 2000s from the National Academy of Medicine, did something similar for the quality improvement movement, showing that what we know works is often not practiced in the real world. And within the last 15 years, the Learning Healthcare System series has come out, which has been quite impactful for AHRQ. And as many of you may know, this is the vision of a learning healthcare system, which is laid out in this National Academy of Medicine report. And it's this idea, and I'm hoping you can see my pointer here, that science can be digested and synthesized into evidence, which is actionable and can impact care. And then we can learn from that care to inform new science. And it's a cycle which is informed by the culture in which it lives, by leaders, by incentives and alignment of incentives. And you can see here that there are a lot of zeros and ones. So this is just making the point that much of this is digital. The synthesis and digestion of science into evidence, implementation of evidence into practice, and how we learn from the clinical practice that we deliver. So this is the vision. This is probably the reality, even at this point today, years after this series was first released. So insights from science are obviously poorly managed and often don't get digested and synthesized into actionable evidence. And even if actionable evidence exists, it often is poorly used. And the experience that we we have in care delivery is often not captured to inform science. So this is something that I term the forgetting healthcare system. But we at AHRQ have very much focused on this ideal, and this ideal is a foundation of the work that we do. And so in the Evidence-Based Practice Center at AHRQ, we're very focused on synthesizing knowledge into actionable evidence that can be implemented into practice and improve care. There's a lot of interest in tools to facilitate the implementation of this knowledge into practice. And then AHRQ is very focused on evaluation as well, evaluating the impact of the delivery of evidence into practice on processes, clinical outcomes, patient-provider experience. And the idea is that this data feeds back to inform knowledge. And again, it's a virtuous cycle, which leads to higher value care for patients. So I think you all know that AHRQ is within the Department of Health and Human Services and the executive branch. Leadership of AHRQ reports up to the Secretary of Health and Human Services, who reports to the President. And within Health and Human Services, there are 11 operating divisions. Everybody knows NIH and CDC and FDA. And there's AHRQ within this milieu as well. The mission of AHRQ is to produce evidence to make healthcare safer, higher quality, more accessible, equitable, and affordable, and to work within the Department of Health and Human Services and with other partners to make sure that that evidence is understood and used. So evidence to support the strengthening of healthcare delivery is really a cornerstone of what AHRQ is all about. And I like this slide because it helps people understand how AHRQ differentiates itself from other operating divisions within Health and Human Services. So many of you know NIH is very focused on cures, particularly for specific diseases, diabetes, cardiovascular disease, cancer, mental health. CDC is very focused on public health. FDA is focused on drugs. And AHRQ is focused on healthcare delivery. I like this slide because it lays out on the right the three major competencies of AHRQ. And this is a slide that the director uses day in and day out. First and foremost is really healthcare delivery science, providing contracts and grants to generate new research, to synthesize research, to disseminate and implement that research. So that's first and foremost. The second competency is practice improvement, and there's a lot of time and money spent around practice facilitation to improve care and improve outcomes. And then the third competency is around data and analytics. For the most part, providing data and analytics to support practice improvement and healthcare delivery science. And many of you know those data sources. There are sources like HCUP, MEPS, the CAP survey, very frequently used data sources. So where does the Evidence-Based Practice Center division sit within AHRQ? So AHRQ has reorganized, to my knowledge, quite a few times over the decades it's existed. And currently, this is the infrastructure of AHRQ. There are three major research centers within AHRQ. There's the Center for Evidence and Practice Improvement, the Center for QI and Patient Safety, and the Center for Financing Access and Cost Trends, which is really the data center. And the EPC division lives within CEPI, the Center for Evidence and Practice Improvement. And it sits alongside the U.S. Preventive Services Task Force Division, which manages the USPSTF preventative services recommendations that come out regularly. It sits alongside the Digital Healthcare Research Division, which does a lot of work in clinical decision support to implement evidence into practice and improve outcomes. Sits alongside the Practice Improvement Division, which does a lot of work around collaboratives, a lot of work around shared decision-making, And lastly, there's the Healthcare Delivery and Systems Research Division. This division is very focused on trying to understand characteristics of healthcare delivery systems that lead to improved care delivery, improved outcomes. So the AHRQ EPC program, it was established in the late 90s, and actually the 25th anniversary is coming up next calendar year, which we're all very excited about. And currently the program contracts with 9 academic research organizations to commission evidence reviews, but also commission research, tool development, and pilots in the domains of evidence synthesis, dissemination, and implementation. And Karen Robinson knows all about this. She's been deeply involved from the beginning. And we also contract with a scientific resource center, which coordinates all of these activities. How are we funded? We do have a line item budget. We have appropriated funds from Congress that we get every year, and we hope increases every year. But importantly, there are other sources of funding that supports the EPC program. One major source is interagency agreements, IAAs. And these come from departments within Health and Human Services, like NIH, CMS, CDC, HRSA. They also come from federal departments that are not in Health and Human Services, like Department of Transportation, VA, U.S. Department of Agriculture. And there are some non-federal sources of interagency agreements as well, like PCORI. And these agreements are essentially transfers of funds to do evidence reviews to essentially support the needs of these different divisions at any given time. And so these are relationships that are incredibly dear to us, important to us, impactful for us. And our aim is always to grow these partnerships even further. And then thirdly, there's the Peace Corps Trust Fund, which I think you all know about. It's supported by the Peace Corps Trust Fund fee that's assessed annually on health insurance plans. It's around $2.50 per covered life that these plans pay into the trust fund. And that results in about $300 to $400 million collected annually. Most of that goes to PCORI, but 16% of that goes to AHRQ, and the other 4% goes to other HHS divisions. And so that supports quite a bit of the work that the EPC does. These are our current EPCs with your EPC on top. And you can see it's a great distribution of researchers and experts across the country. And I see Eric here too. Eric's obviously been critical to the Hopkins EPC along with Karen. We have a robust staff within the EPC division at AHRQ who develop and manage the contracts and grants that the EPC division supports. And this is a really talented mosaic of individuals who have been very committed, many of them over many years at AHRQ, ranging from physicians to PhDs, to nurses, to healthcare administrators, PharmDs. It's a wonderful mix of people and wonderful talent and expertise. So the vision and mission of our EPC program specifically, the vision is that all healthcare decisions are based on the best available evidence, resulting in the best health outcomes. And our mission is to transform healthcare by increasing the quality, availability, and use of evidence via rigorous and unbiased analysis of evidence. And our program has 4 goals to support that mission. The first and foremost is producing high quality reviews. But second is building and growing impactful partnerships. The third is advancing methods in systematic reviews. And the fourth is improving the evidence base more generally. And we publish an annual report each year that helps us understand how well we're doing in meeting each of those 4 goals. And you can see in this slide here, the type is a bit small, but each of the goals is color-coded. And for example, for Goal 1 for calendar year 2020, we produced 32 systematic reviews. In terms of Goal 2 partnerships, we had 22 different partners who we worked with. Goal 3, in terms of methodology, we produced 5 reports on new methods. So you get a sense of how we keep track of our goals. Now, this is a really important question for all of us within the EPC division and AHRQ and HHS more broadly. What is the impact of the EPC program? And I like this slide. We call it the Porter question from John Porter in the late 90s, the Committee on Appropriations. And he asked this question: what we really want to get at is not how many reports have been done, but how many people's lives are being bettered by what has been accomplished. In other words, is it being used? Is it being followed? Is it actually being given to patients? So we take this concept very seriously. And as part of our annual report, we put together 5 impact report stories. And this is just one example of an impact story from 2020 that was in our annual report. As some of you may know, the NIH published a new asthma guideline in December 2020. The prior one was almost 15 years old, and an update was important because there are a lot of new treatments available for asthma. So the NIH commissioned 5 systematic reviews from the EPC program, and these reviews were the foundation for this guideline. So if you haven't guessed already, partnerships are incredibly important for the EPC program. For us to have any impact, we have to have strong partners. And in this slide, you see probably the 3 most common partner groups that we work with. So research funders like NIH and PCORI use our systematic reviews to prioritize and develop research agendas. We're very proud of that. It has a big impact. Guideline developers like the NIH or many clinical societies use our reviews to inform clinical practice guidelines. Policymakers, in particular payers like CMS, use our reviews to inform coverage decisions. And these are some of the example partners we've worked with over the last year. You can see those first 3 are all within Health and Human Services, but also departments in the executive branch outside of Health and Human Services like DOT and Congress we do reviews for, and I'll share some of that in a few moments. And then a lot of non-federal groups, including clinical societies. These are some of our ongoing governmental, quasi-governmental partnerships. So these are not one-offs, but these are relationships that have existed for years. And I won't go through all of them in detail, but it sort of starts with the USPSTF, which we've been doing reviews for since the mid-'80s, to CMS, all the way up to PCORI in the present, where we do a lot of reviews to inform their research agendas. So what exactly is an AHRQ EPC systematic review? I don't want to go through this in too much detail because you all know this as well or better than I do, the rigorous methods of systematic reviews. But in general, these are summaries of overall evidence to address sets of key questions that are relevant to end users. They're protocol-driven, comprehensive searches of existing peer-reviewed scientific literature. We critically appraise each published study identified, and we summarize findings for each key question across many relevant outcomes, including benefits, harms, patient-provider preferences. Our methods are informed by the standards that have been set by the National Academy of Medicine, and these standards were developed in part with the help of our program. Types of evidence reports. This slide is just a reminder that we don't just do systematic reviews, but our methods have evolved over time and are becoming more and more agile. We do evidence maps. We do rapid reviews. You'll learn in a moment that we're doing living reviews. So the products are diverse and are intended to meet the needs of end users. What do AHRQ reviews address? Well, there are a range of topics, and I think historically, a lot of the topics that reviews have addressed have been point of care clinical questions. You know, for example, does this drug work? Does this device work? Comparative effectiveness questions. I'll tell you, and you'll see through some examples in a moment, that more recently, a lot of our topics are really focused on healthcare delivery and how to support healthcare delivery to improve patient care in many different dimensions. And our reviews address the needs of our stakeholders, and those have included patients and clinicians from the beginning and have evolved to include research funders, payers, and more recently, healthcare systems. Unique characteristics of EPC reviews: well, scientifically rigorous, independent, and unbiased. We evaluate conflicts of interest for all contributors. And stakeholder-driven. Stakeholders identify evidence needs, help us develop these reviews, and disseminate and implement the reviews. And I wanted to take just a moment to talk about stakeholder engagement, because it's a critical part of the process from beginning to end. The public can suggest topics for nomination, and we work on a lot of topics, particularly using P Corps Trust Fund dollars that are nominated by the public, including many professional societies. Scoping, we rely on technical experts and public comment. Same for protocol development. Same for systematic reviews, and the public can submit research studies for inclusion. We have peer review and public comment on drafts of our reports, and we post disposition of comments after the final report is posted, just for transparency's sake. So a lot of opportunity to be involved in these reviews, and many of you probably have been involved in these reviews. So the Effective Healthcare Program website is, for all intents and purposes, the website home of the Evidence-Based Practice Center program. This is our website from beginning to end. And if you want to get a sense of the work that we're putting together, if you can see here, this products tab is probably the best first place to go. And if you click on products, you'll be able to search our products from most recent to least recent. And so what I'd like to do over the next few minutes is just go through some of the common themes where we've been working over the last year or so, to give you a sense of what we're working on, and also review some of the methods that we've been utilizing to address these topics, because many of these methods are newer methods for us over the last few years. And then I'll end by going through some near-term next steps for the program. So the first theme I want to cover is healthcare systems. We've been doing a lot of evidence reviews to address the needs of healthcare systems, and you see some of those reviews here. I won't go through all of them. For example, strategies for patient, family, and caregiver engagement. This is a review that I believe Hopkins has worked on. Other reviews: interventions to decrease hospital length of stay, management of high-need, high-cost patients. So these are topics that are of deep interest to healthcare leadership. They need help addressing these issues, and historically they haven't had a single place to go to get syntheses of evidence to inform their decision making. And many of these topics came from a learning healthcare system panel that the AHRQ EPC program contracted with over the last 3 years. The panel actually just closed last month. But the goal of the panel was to get a group of learning healthcare systems together to understand what are the issues of interest to learning healthcare systems more generally. Are we meeting those needs? If we're not, how can we address those topics, and how can we help them nominate those topics? And then how can we help the learning healthcare systems use the findings from those reports in their day-to-day decision-making? And these are all of the different healthcare systems that participated in the panel over the last 3 years. Many of these are well-known healthcare systems across the country. And one of the learnings that came out of this panel, besides all of the topics that they nominated and all the work that our EPCs have done to address those topics, one of the learnings was, even when these topics are completed, even if they're relevant to us, and those topics, those PDFs are posted on the AHRQ website, oftentimes when you go to the site, you have to go to the PDF and they're dense, and you have to get through the report to find the findings that are relevant to decision makers before they act on them. And they really cited that as an important barrier. So in a lot of conversations with this panel over the years, and some development and usability testing, these interactive data visualizations were developed to help healthcare system leaders more directly interact with the findings and reports. So instead of going to the AHRQ site and finding a link to a PDF, you can go to the AHRQ site and find this dashboard alongside the PDF. And you can interact with this dashboard. It helps surface the findings, and it helps the team review the findings in group settings to make decisions. And so this is just one example of a visual dashboard for the reducing hospital length of stay topic. And you can see here that you can select the different interventions that are in the report, select the outcomes that were available, select the populations that were studied, and get a sense of, for example, do clinical pathways reduce length of stay? And if so, what is the impact on readmissions and mortality? And you can get a sense of the direction of effect and the strength of evidence, and dig more deeply into those findings through this interactive visual dashboard. Another theme of our reports is digital health. And we've done a lot of work in digital healthcare over the last year or so. And these are some of the most notable reports, but others are on the way. The racial bias in healthcare algorithms report was actually one that was requested by Congress, and we've used appropriated dollars to do that work. We've also done, are in the midst of completing a report evaluating mental health mobile apps. Again, I think this is work that Hopkins is engaged in. And, even all the way at the bottom of this list, telehealth for women's health. So this is a topic that was requested by HRSA. HRSA, as many of you know, provides grants to support federally qualified health centers. And HRSA had a lot of interest in the role of telehealth to support reproductive health, prevention of STDs, prevention of intimate partner violence for women served in FQHCs. So we're doing this report for HRSA to inform their guidance for those clinics. And just to give you a sense of how the questions that we're addressing have evolved over time. So check out these key questions in the racial bias in healthcare algorithms report. So these are not questions about drug A versus drug B or device A versus device B. There's a lot of complexity to addressing these questions, and the EPCs have developed a lot of skills and methods over the last number of years to do this work. So key question one, what is the evidence that algorithms and algorithm-informed decision tools contribute to racial ethnic disparities? Key question two, what approaches have been used to mitigate bias in the development of algorithms and decision tools? In a similar way, the mental health mobile apps questions are very complex, as Karen and Eric can tell you. Guiding question one, what minimal standards should be analyzed to assess the appropriateness and effectiveness of behavioral health mobile apps? And then guiding question two is identifying or developing an assessment framework for evaluating apps and applying the framework to help users select apps. So these are highly advanced key questions that are driving our systematic reviews. And because of that, we've really had to drive our methods to keep up with the complexity of these questions and the needs of our end users. we're doing a lot of reports in the area of maternal health as well. That's another theme. And this is of particular importance to the current administration. And it's of particular importance to PCORI as well. So most of these reviews have been sponsored by PCORI IAAs to the AHRQ EPC program, and have been sponsored by ACOG as well. Another theme that we're doing a lot of work in is acute and chronic pain. We've done not only reviews, but frequent review updates on acute and chronic pain management to inform CDC guidelines. So these are new methods for us, doing frequent updates as part of a single contract to keep a guideline up to date, particularly in areas where the research is evolving rapidly. In a similar way, Congress asked us to review the evidence on the use of cannabis and also kratom for treatment of chronic pain. And so we're currently doing a living systematic review on cannabis and other plant-based treatments for chronic pain. And we're keeping that review up to date with regular surveillance reports. The last one was published in October 2021. And just to give you a sense of how our methods are advancing, so this is an interactive data visualization that's going along with the living systematic review. And these are tools that we learned about from the Learning Healthcare System panel, and we're starting to incorporate into more of our reviews. And this will allow us to keep the evidence review up to date in a much simpler way, and keep those new findings at the surface of our website, and make it easy for folks to access and interact with. So if you continue to look in our Effective Healthcare Program website, you'll find a section on methods as well. And we have a lot of our core methods reports on this site, such as methods guides for effectiveness and comparative effectiveness reviews, methods guides for medical test reviews, but also many of our white papers, many of our new methods reports are also on this site. And I just want to flag a few. So this is some recent methods work that we've done, improving the utility of evidence synthesis for decision makers in the face of insufficient evidence. You'll notice that much of this recent methods work is focused on end user needs and making our reports as usable as possible. This last methods piece on this slide, integrating health system data with systematic reviews to complement this systematic review to provide more information to end users. So these are 5 recommendations that came out of the white paper looking at improving utility of evidence synthesis in the face of insufficient evidence. And a lot of this is about if there isn't sufficient evidence, can the scope be expanded to include indirect evidence? Can we summarize more than just benefits and harms data, but can we summarize information that's contextual or descriptive, or that helps people understand applicability of evidence or feasibility of implementation of evidence? And last here, you see incorporating healthcare system data into the review. Are there opportunities to do that to supplement the limitations of existing peer-reviewed information? And we did a separate white paper on this specific topic, integrating health system data with systematic reviews. And this is a figure from the peer-reviewed publication that summarizes this work. So if systematic review or health system data are limited, using both types of evidence together may improve the strength of evidence, improve applicability, improve implementation. And if this is an area of interest to you, the use of primary data alongside systematic reviews to provide even more actionable evidence for end users, then I'd recommend looking at this paper. There are a set of 4 recommendations that this paper ends with as well. And these review methods that are very focused on end users are not new to the AHRQ EPC program. I mean, this is work that's been going on over the last decade. And when I joined the AHRQ EPC program in 2012, when I was at the University of Pennsylvania, and we partnered with ECRI to become the ECRI Penn EPC, a lot of this work was just getting underway. And I remember being involved in 2014 in work suggesting methods on how to best systematically review complex multi-component healthcare interventions. So these are the interventions that are often used in healthcare delivery systems, in QI initiatives and infection control initiatives. And how do we understand what the active ingredient is in those bundles? Did a lot of work around 2015 around rapid reviews to better meet end user needs. Work in 2017 around understanding evidence needs of healthcare systems. And that culminated in 2019 in a series supported by the EPC program, looking at improving translation of evidence reviews into practice across learning healthcare systems. And this supplement in the Joint Commission Journal details a number of pilots that took place across the country in implementing evidence into practice in different ways. Anyone can request an evidence review, and the ability to do that is through our website or through contacting us directly. And when we get requests for evidence reviews, we have a very detailed process to prioritize which topics we're going to move forward with. And the process is transparent. We ask if the topic that's being nominated is appropriate for review. Is it an important topic? Have recent reviews been done? And if not, that's a good thing. We can make an impact. Is there existing research that we can synthesize? Are there identified end users who are willing or excited about using the review? So these are all things that help us prioritize which topics to work on. And besides doing reviews, there are a lot of other different contracts and grants that the EPC program supports. And I didn't want to go through all of those in depth, but I thought I would take just a moment to talk about the Systematic Review Data Repository, SRDR. It was launched in 2012. Let me go back here. Redesigned in 2018. And it's an online open access tool to enable the conduct of systematic reviews. And it stores data from, at this point, 200 completed systematic reviews with over 20,000 individual studies. And we just put out a new developmental task order to look for partners to help make SRDR Plus more interactive with other digital resources, such that, for example, you could go to PubMed, and if you find a study that's been included in SRDR, you can directly go to the risk of bias assessment that's in SRDR for that study. Or you can go to clinicaltrials.gov, and if you find a study that's been conducted and completed, you can go directly to SRDR to find the extracted information from that study, including a quality assessment, if that study's been extracted into SRDR. So these are the types of things we're thinking about with SRDR in the future. So to close, I recently joined the AHRQ EPC program in July, and there are what I call 3 C's of the EPCs that we've been really focused on in the first 6 months or so of me being in the program. And those C's are here: collaboration, communication, and continuous quality improvement. I just want to share in a couple slides work that we've been doing in each of these domains in the last few months. So in terms of collaboration, we have a lot of interest now that the first iteration of the Learning Healthcare System panel is closed in November, to think about what a 2.0 panel might look like. And we're engaging with CMOs, COOs, nursing societies, and leaders to think through what that might look like. I think knowledge brokers are an untapped partner for the EPC program, really understanding what are publishers' needs from the EPC program? What are EHR vendor needs? And how can those publishers, EHR vendors, leverage our different resources, our different tools in their products so that they're even more available to the public? So those are relationships that we're starting to build, and we're continuing to nurture and strengthen existing partnerships as well. We spend a lot of time doing that, and that's key for us. Communication is also really important. There are a lot of opportunities to strengthen our communication. I found that the Office of Communications at AHRQ is extraordinarily willing and eager to work with us to improve the accessibility and usability of our products. And we've been spending a lot of time with them in the last few months to do that. We've been spending time with them on EHC website refresh, and hopefully you'll all see some of that in the coming months. They've also been working on some infographics to engage readers in our reports. When we publish our reports on the website or share the link of our reports through social media, what we found is that if we share those reports with videos or graphics, the click rate and the eyeballs looking at those reports is much higher than if we just share those links embedded in text. So working on some infographics to further engage readers. And these interactive data visualizations are becoming more and more a part of the mainstream production of our reports. And so I just want to show you some examples. So this is the current web page for a report on managing primary headaches in pregnancy on our website. Now, I wanted to fit the entire page and all the text in the page on this one slide, so that's why these words are tiny here. But I want to show you what our NexGen site for this same report looks like, and this is what we're aiming for in the next couple months. So this is our NexGen site. Again, this is including every single word on the page, but what you'll notice is the report is more accessible. Different sections of the report are easily to access quickly. The main findings are right in front of you. And there are complements to the PDF, like visual dashboards that you can open and drop down menus and interact with. And this is just an example of an infographic that's just been produced for our Cannabis report, helping people understand what products were studied in the literature and were reviewed, and what were the general conclusions. We've also done a lot of work in continuous quality improvement, which Karen and Eric can tell you about. We've had 2 initiatives going on in the last few months. One is we have a new research and evaluation fellow who started just a couple months after I did, who's led a process mapping initiative to streamline the work of the EPC program and the EPCs themselves. And we've had Susan Norris, who's a notable figure in the world of systematic reviews, produce a report commissioned by our Scientific Resource Center, evaluating the presentation, timeliness of our work over the last number of years, and the ability of our work to clearly address end user needs. And based on her review, she's developed a typology of problems and proposed recommendations. And so both of these reviews have helped us create a number of action items, which we're currently working on around supporting our guidance, around streamlining peer review, strengthening training, strengthening the contracting process, all to streamline the work and make the work more usable and actionable and rigorous. And lastly, there's a lot of excitement around our 25th anniversary next year. You know, beyond EPC T-shirts, you know, I think we've got a lot of plans in store, including a Grand Round series, which we hope to support, journal articles, impact awards for our EPCs for impactful reports. So more to come in that area. So I hope I've convinced you that the current EPC program is not your parents' EPC program, and we've done a lot of innovations over the last number of years to address emerging needs of new end users. And so in conclusion, AHRQ is focused on evidence to improve healthcare delivery. Our program's impact stems from its partners, and our approaches need to be agile to best meet our partners' needs. And this requires innovation in our methods, but also how we communicate our findings and engage end users, and how we identify and collaborate with the partners who are most in need. And this hopefully allows our evidence reviews to not only inform guidelines and policy more broadly, and practice change and further research, but hopefully improve health outcomes. That's our goal. And as an aside, I just wanted to let folks know, and please do pass this on to your peers who may be interested. We actually have an open position for a Director of Technology Assessment at AHRQ who would live within our division. These are obviously people who could manage a comprehensive national tech assessment program, interact with CMS and others nationally and internationally, and really represent AHRQ in this space. And these can be folks who are experts, whether they're PhDs or physicians or both. We're eager to see who might be interested in this role. And the position's open until Monday, January 3rd. So if anyone has interest, they can feel free to contact me directly. Happy to talk through it. And lastly, if you don't get our updates, there's a really usable way to sign up for email updates on the AHRQ site. So please take advantage of that. So I think with that, I'll stop and I'll punt it back to Karen and Taylor.
Great. Thank you, Craig. And thank you maybe for aging Eric and I, and noting that we have been at the EPC since the beginning, 25 years ago. That's a little scary. I have a number of questions jotted down, but some of them are maybe a little esoteric for this group. So I'm going to start with one that Janet posted in the chat, which I think is an interesting question for us. As you know very well, we've long had a prohibition against using cost or assessing cost in the reports. Some limitation on how we can discuss cost. Eric suggested that might have loosened a little bit recently with legislation, but could you talk about maybe a little bit of the history of why there's that restriction, and if that has indeed changed, if we can address that?
Yeah, I'll try to address that. What I'd say, I think historically, cost has been a moving target because of the argument, which you probably all know well, which is cost can be very dynamic and be dependent on local populations, payers, coverage. And I think, the focus has always been effectiveness and comparative effectiveness and safety. If it's effective or comparatively effective or safe, that's important for the program, for PCORI to identify. And then, nationally, as we talked about before we got started with CMS, or regionally with various payers, they can decide, whether the costs are worth the benefits. And that may very quickly change over time. So I think historically the focus has been on effectiveness and safety for that reason. Does PCORI now allow cost-benefit analysis in the new reauthorization? Well, I can tell you that I think Eric is right that the new reauthorization allows for cost to be a part of the discussion. There may still be specific restrictions around cost effectiveness analysis, but that doesn't mean that cost can't be described, as part of the contextual information in given research. There's no longer that restriction on including a description of utilization cost in work, and so that's PCORI's new approach. Does AHRQ have similar restrictions? That's a great question, and I have to find the answer to that. If AHRQ's position has changed alongside PCORI, obviously AHRQ benefits from those PCOR Trust Fund dollars similar to PCORI, but the PCOR Trust Fund that funds AHRQ is not PCORI, although the legislation that authorizes the PCOR Trust Fund fee is relevant for both AHRQ and PCORI. So that's something that I have to get back to you on. I wish I had a clear answer for you.
Okay. Christine points out that that we can, of course, talk about resource utilization, which is a little different, but does get at obviously get at some aspects of cost. Please feel free to put questions in chat or raise your hand. Hopefully I'll be able to see a hand raised. Again, trying to pick non-esoteric questions to ask you. I think you talked a little bit about opportunities and next steps, but I wonder if you could, given that it is the anniversary, put you on the spot a little bit, and assuming EPC program is around in 25 years, and another 25 years, what does it look like?
Yeah, well, my hope is first and foremost that the EPC program is identified and is a recognizable partner, not only across HHS and the federal government, but across the country. I'm continually surprised, and I don't know if you've all had this experience as well, that everybody knows the NIH for obvious reasons, or the CDC. Many folks, including medical students, residents, even some of our faculty at prestigious medical centers are not aware of AHRQ. And I think particularly as the country makes more and more investments in the healthcare delivery infrastructure, I would like AHRQ's role to be recognized and appreciated more by our different partners, and for the EPC program specifically to be used by those partners. So that would be my first hope, that there's more resources to support AHRQ and the EPC program and more use by varied partners. I think my second hope, and what I'd like to see in the next 25 years, is that we're working on really a diverse array of topics, and we're using advanced methods to best meet the needs of end users. So one of the ways that I think some folks are frustrated more generally in systematic reviews, and sometimes this might apply to AHRQ EPC reviews, particularly in the past, is where a question is asked and the answer is insufficient evidence. I don't think that's good enough. I think we have to help people make decisions. And I think, for guideline committees, we provide the information they need to help inform their recommendations. The same working with policymakers. The same has to be true for healthcare system leaders. We really have to give them information that can help them make the best decision. And saying insufficient evidence is just not adequate. That doesn't mean that for some areas, that's not appropriate. But I think it's not a good way to start, and we have to give some people information to make decisions. So, I would like to think that the program within the next 25 years can continue to evolve methods to address the needs of end users. And then I think, the ability to integrate these findings into decision making. We're doing a lot of work now with data visualization, but the more we can surface these findings and make them easier to use and make them even seamlessly integrate them into decision making through digital means, collaboratives, working with other partners to align incentives, I think the better off we'll be. So those are some loose visions for the next 25 years.
Great, thanks. So another question that Eric posted is about the National Guideline Clearinghouse. And as some people know, ECRI was contracted through AHRQ for many, many years to manage the National Guideline Clearinghouse. That funding ended 4 years ago now. And I think that ECRI, and you can speak to this more than I can probably, has continued to develop or have a guideline database. There's also the GIN, Guideline International Network Library. But recently AHRQ put out a call for, I guess it was a request for interest maybe, of people to, with a no-cost contract to develop the National Guideline Clearinghouse. Could you talk about that a little bit?
Sure. Yeah, I can share with you what I know. And this is out of the Division of Practice Improvement within the Center for Evidence and Practice Improvement. So you're totally right, Karen, that the National Guideline Clearinghouse was an incredibly valuable resource. I think many folks within and outside of AHRQ were very disappointed when AHRQ was unable to continue to support the National Guideline Clearinghouse. ECRI, which was the contractor who managed the National Guideline Clearinghouse, you're right, did continue to support the National Guideline Clearinghouse under the name the ECRI Guideline Trust. And that trust is, that information is available, continues to be available, I think, to ECRI clients as well as the public. I think you do have to provide some information in order to get access to that guideline trust. So some people may be hesitant about that. But I think, what we've understood is that, some guideline committees and professional societies may be hesitant to provide all that information around their guideline to ECRI if, the trust is ECRI specific and not necessarily supported by the public. Mm-hmm. So there's been renewed interest at AHRQ in re-supporting the National Guideline Clearinghouse, but thinking about how to do it in novel ways. And so that's what this request for information around a no-cost contract is. And what the idea is, to my knowledge, is that AHRQ would allow the contractor all the access to the information within the Guideline Clearinghouse, the infrastructure. They wouldn't provide any funding for that contractor. But on the flip side, the contractor can think about novel ways to generate revenue from their support of the National Guideline Clearinghouse. Whether that's, for example, a publisher having more people come to their products because they're housing the National Guideline Clearinghouse, or other mechanisms. So that's the idea of that request for information. And we're trying to understand different perspectives on how that could work. Great,
thank you. I think we're at the end. I'm getting a little meeting reminder that I should be somewhere else. So thank you very much, Craig. Really appreciate you joining us and speaking with us today. Thank you so much.
Yeah, thanks for having me. I appreciate it.